Hello, I'm Pradeep Bollu. I'm a neurologist at MU Health Care. I hope you and your family are safe and sound in this pandemic. Welcome to the Parkinson Disease Annual Patient and Caregiver Conference. This year, we are going to do it slightly differently in the form of presenting our topics as web series. The topic I have for you today is sleepiness and fatigue in Parkinson's disease. For this presentation, I do not have any relevant financial disclosures. The material is collected from the internet and some of it is not my own. First of all, let's start our discussion by talking a little bit about fatigue. Let's define fatigue. What is it? Fatigue is basically an overwhelming sense of tiredness, lack of energy, and feeling of exhaustion. You can also say fatigue as a subjective lack of physical and or mental energy that is perceived by the individual or the caregiver, which would interfere with usual and desired activities. Fatigue is very prevalent and a very disabling symptom in Parkinson's disease. Up to 2/3 of people who have Parkinson's disease are affected by fatigue. Where does this fatigue come from? Well, it can be coming from the brain, the central nervous system, or it can be coming from the periphery, the arms or legs. Within the brain, the fatigue can be a mental lassitude due to hypovigilance or a mental lassitude due to hypervigilance. Let me take a moment to explain what I'm talking about. Say, for example, a patient with Parkinson's disease who has a lot of stiffness, who has a lot of slowness, difficulty with ambulation, sitting down in a house with not a whole lot of stimulation from outside, stimulation from friends and family. Due to the lack of stimulation, there will be a state of reduced vigilance. So this is what I'm talking about when I say mental lassitude from reduced vigilance. On the other hand, the vigilance can be very increased because of too much stimulation from outside. Let's take an example of too much news from our media outlets talking about different points of view. You just can't focus, you just can't process, and all of that results in a state of mental fatigue. So a fatigue, the state of fatigue can be the result of too much vigilance or too less vigilance. In Parkinson's disease, fatigue can also be coming from the periphery. What I mean by that is people with Parkinson's disease have stiffness and slowness. Even when the brain is trying to push your arm or leg to move this way or that, it's very difficult to accomplish what your brain wants to do. And this can result in a state of peripheral fatigue. So let's talk about all the different reasons why patients with Parkinson's disease can become fatigued. The fatigue can come directly from the disease, directly from the damage caused by the disease in the brain and the periphery. The fatigue can come from the treatment we physicians give to the patients. Fatigue can come because of the effect of disease on sleep. Fatigue can come from poor nutrition. Fatigue can come from mood problems like anxiety or depression. And we will go over these different potential sources of fatigue one after the other, and I will take some more time to go into sleep-related causes of fatigue in detail. First of all, let's talk about the disease-related fatigue. Parkinson's disease is a neurodegenerative disease. In this disease, brain cells die. This is because of abnormal protein that gets deposited in the brain cells, resulting in damage and destruction of these cells. As these cells start to die, they result in a state of increased fatigue. The disease has also, as one of its core components, slowness. As one of its core components, stiffness. So this slowness and stiffness brought on by the disease can also result in a state of fatigue. Well, when someone comes with Parkinson's disease, complain of slowness and stiffness, they are tired all the time, What does the physician do? Well, establish the diagnosis, then initiate appropriate therapy. One would think that initiating treatment can help with the symptoms, can improve the quality of life. Well, that's true for most part. However, the treatment initiated for the sake of helping the symptoms of the disease sometimes can be the cause of fatigue. One good example would be medications like dopamine agonists. These are the medications that are typically used in the beginning of the disease process to help with the motor symptoms of Parkinson's disease. Your doctor may discuss with you about the potential side effects of these medications. Well, the aim of the physician is to help with your slowness and stiffness. However, it's sometimes the case where the medication itself brings on fatigue. Fatigue can be because of problem with your sleep as you are navigating the entire disease with your caregivers. You can have a variety of sleep related problems, and we will get into details of each of these problems in Parkinson's disease that affect your sleep. The sleep problems can be fragmentation of your sleep because of sleep apnea, insomnia, which is difficulty with sleep, restless leg syndrome and excessive movements at night time, REM sleep behavior disorder. This is where you act out of dreams. Poor sleep hygiene. It could be a habitual thing that you have developed maladaptive behaviors that now result in poor sleep. It could be because you wake up constantly in the middle of the night to go to the restroom, nocturia. Sometimes you can experience symptoms like night sweats that can also interrupt your sleep. And we shall discuss all of these things in detail in the subsequent slides. So fatigue can be coming from the sleep problems which are part of the disease, part of the treatment process. And other causes of fatigue, a coexisting mood disorder like depression or anxiety can make the fatigue worse, can bring on fatigue. So talking to your physician about your anxiety, about your depression, about your mental health issues is very important when you are addressing fatigue in Parkinson's disease. It is also not uncommon to see that people with Parkinson's disease lose their appetite. They have nausea. Medications can sometimes make the nausea worse. As a result, a lot of patients lose weight. They become skinnier. Their nutritional status goes down. The food they eat may not contain enough vitamins and minerals. And this can make the fatigue incredibly worse. A lot of these patients end up having reduced amounts of B12, folate, vitamin D, etc. So poor nutrition is another reason why fatigue is quite prevalent in Parkinson's disease. As I said, I would want to take more time in discussing the sleep and the problems you see in sleep that would contribute to fatigue. So I have a very good quote from Joseph Kosman about sleep. The best bridge between despair and hope is a good night's sleep. And this is very true. First of all, let's talk about sleep apnea, because this is a very prevalent condition in the community. In Parkinson's disease also, the prevalence of sleep apnea is very high. So let's take some time to understand what sleep apnea is. As you know, when you're awake, you're breathing air in and out without any problem, because the airway is fully open, letting the air in and out. However, when you go to sleep, the same airway now starts to become a little collapsed. The muscles surrounding the airway becomes less tight. They start to become a little easy on themselves, resulting in a state of narrowed airway. And this is something that happens in everyone. Whenever we sleep, the airway collapses a bit. In most people, that collapse is not enough to cause any problem. However, in some people, that collapsed airway becomes a little too narrow, where the airflow into the lungs and to the outside becomes turbulent. And this turbulence results in your brain constantly waking up. And when the brain constantly wakes up, it tries to open up the airway. And that results in airflow that is smooth and effective. But this process continues the entire night. So the brain constantly wakes up from deep sleep into a light sleep so that your airway opens up. And when this happens, basically the brain is not getting enough deep sleep. And when the brain is not getting enough deep sleep, it goes into a state of sleep deprivation. And this has many bad consequences. The most common form of sleep apnea is obstructive sleep apnea, where the upper airway gets collapsed by the soft tissues surrounding it, and more importantly by the tongue that falls backwards onto the airway closing it. So when someone has sleep apnea, they experience daytime sleepiness. They experience a sleep that is not refreshing. They wake up in the morning feeling tired. They may sometimes have a morning headache. The patient themselves can sometimes realize they are snoring when they are sleeping. And the bed partner typically is the one to tell them that, hey, when you're sleeping, you snore. So when you have symptoms like this, loud snoring, non-restorative sleep, daytime sleepiness, morning headaches, that is when you should start to suspect that maybe there is obstructive sleep apnea. And that is what you need to bring up when you see your neurologist talking about your tremor and stiffness. Bring up this issue of the possibility of sleep apnea. And how do we treat it? Well, first of all, let's talk about how do you diagnose it. Well, after you describe your clinical symptoms, when the concern for sleep apnea exists, you are asked to undergo a sleep study, which is basically you sleeping in a sleep center or sleeping in your bed, putting some equipment on you, letting the equipment record your breathing patterns, and then we will analyze the data from the recording and see how your breathing is, whether there are any irregularities in the breathing, whether your oxygen saturation is dipping down. So when we analyze this data, we come to a diagnosis of whether or not you have obstructive sleep apnea. Once the diagnosis is made, the next step is treating sleep apnea. And how do we do that? The most common treatment for sleep apnea is CPAP therapy. Basically, think of your upper airway as a balloon, a long balloon. When it is deflated, the easiest way to inflate it is by blowing air into the airway, and that's exactly what CPAP therapy does. You have a mask interface that sits on the nose and sometimes on the mouth, pushing air in, opening the airway like a balloon. So the splinting opening of the airway is how your obstructive sleep apnea is treated. And this is a very effective therapy. In some patients, there is a difficulty tolerating CPAP therapy. In those people, we have other options like using mouth guards. In some patients, avoiding sleeping on the back. So depending upon what your sleep study shows, the treatment for sleep apnea can be tailored to individual patients. So that is obstructive sleep apnea, the most common form of sleep apnea, resulting in a state of sleep fragmentation and thereby resulting in daytime sleepiness and fatigue. Insomnia. This is another reason why patients with Parkinson's disease can be fatigued, can be tired during the daytime. Well, what is insomnia? Insomnia is difficulty with sleep. You can sometimes have difficulty falling asleep. You can have sometimes difficulty staying asleep, sometimes both. Sometimes you fall asleep reasonably okay, stay asleep through the night, but when you wake up in the morning, you don't feel like you had a good night's sleep. So your perception of the quality of sleep is also low. So that is insomnia. And insomnia is very common in Parkinson's disease. In fact, it's the most frequent sleep disorder in Parkinson's disease patients. There are certain risk factors for the development of insomnia. This is true with Parkinson's disease patients also. And they include being a female, having a worse disease, having a long-standing disease, having coexisting depression, having coexisting anxiety. So if you have all these, your chance of having insomnia are going to be more. And when insomnia exists, it can contribute to daytime fatigue. It can contribute to not having a good energy to do what you want to do during the daytime. So if someone with Parkinson's disease is experiencing this, bring it up with your doctor so that a proper treatment can be initiated. As I said, insomnia in Parkinson's disease can be multifactorial, and this is a nice picture to show you what are all the different risk factors or contributors of insomnia. One, coexisting mood disorder. Having depression or anxiety can take the shape of insomnia, can fragment your sleep along with making you feel low. So try to look into mood problems, discuss with your doctor, talk about your mental health issues. Sometimes insomnia may be because of your motor symptoms. Let's say, take for example tremor. An elderly male who is having tremor that is not fully controlled can bother them, especially when they are trying to fall asleep. Their hand is constantly shaking, and that keeps them from falling asleep. So insufficiently treated motor symptoms of Parkinson's disease can sometimes result in insomnia. When that is the case, talk to your doctor. In many cases, there can be a modification of your medication regimen that can fix this tremor and can help you with sleep. Other contributors of insomnia include pain and stiffness. Parkinson's disease patients, more than general population, suffer from pain-related problems. This can be because of stiffness of the muscle. This can be because of old age, wear and tear, and all that stuff. Pain and stiffness during the night can prevent them from getting a good night's sleep. So discuss whether you have any pain-related issues with your doctors, because a simple medication can help lower the pain and improve the quality of your sleep and thereby improve your daytime function. Sometimes Parkinson's disease patients can have restless leg syndrome, and we will talk about restless legs in the next few slides. But the presence of restless leg syndrome can make your nighttime leg movement significantly worse, making your sleep very fragmented. End result, you wake up in the morning, you don't feel like you had a good night's sleep. So if that is the case, talk to your doctor. Medications exist for the treatment of restless leg syndrome and leg movements at nighttime, and by making them less, we can improve the quality of your sleep and thereby improve your daytime function. Now let's jump to excessive daytime sleepiness. Up to 1/3 of patients with Parkinson's disease can have excessive daytime sleepiness. If you have a disease that is long-standing, you're more likely to have daytime sleepiness. And the presence of daytime sleepiness can have a huge impact on the quality of life. The most important thing is early recognition and prompt management. What comes to my mind is an example of an elderly lady with Parkinson's disease. She had a lot of daytime sleepiness. Till she came to me, she thought that the sleepiness is just part of the disease. When she was put on medications, her tremor got better. So she thought, well, the tremor is better and the sleepiness is still there, maybe that is what it is. She continued to suffer from sleepiness. Once I saw her, I was able to tease out the reason for her sleepiness. Well, that patient ended up having sleep apnea, and when we took care of the sleep apnea, she became a lot less sleepy, her quality of life improved. On top of sleep apnea, many other diseases that fragment your sleep can cause sleepiness. Even if you don't have any problem with your nighttime sleep, you still may have daytime sleepiness. And we believe this daytime sleepiness that is there even in the absence of other sleep problems is likely due to the damage the disease causes inside the brain. Whatever the case, the presence of daytime sleepiness should be taken seriously and should be addressed when it is impacting the quality of life. Many medications exist to help with the daytime sleepiness. So talking to your doctor should be the first step in trying to identify why sleepiness exists during the daytime. Well, some of the things that you can do without taking medications are following a good sleep hygiene, going to bed at a given time, waking up at a given time, so having a regular sleep routine. Sometimes daytime sleepiness can be because you're taking too much medication, so you can discuss with your doctor that, hey, I'm taking 3 pills of Cinemet every time, or like 2 milligrams of ropinirole or pramipexole. Well, I think I might get away with just half the dose. My tremor is not that bad even when I take the half a dose. So your physician can now try a lower dose, which may fix your daytime sleepiness because the sleepiness was coming from the medication. So that is one strategy, trying to see if lowering the medication can help with the daytime sleepiness. Of course, always we look into other possibilities like sleep apnea or leg movements at night time and all that stuff. And if there is something like that, address them. Address the coexisting depression. Sometimes we take care of anxiety, we take care of depression in patients with Parkinson's disease, but sometimes when things get a little complicated, we seek the help of psychiatrists and psychotherapists. So together we can make a positive impact on mood and thereby help with your sleep quality and thereby lessen the daytime sleepiness. But if none of these interventions work, we have medications that can be used more or less safely in patients with Parkinson's disease that can help with the daytime sleepiness, that can lower your sleepiness and improve the quality of life. Some of the medications include modafinil, the brand name is Provigil, methylphenidate, the brand name is Ritalin. Of course, our most ubiquitous drug, caffeine, which can help with your daytime sleepiness. Now let's talk about restless leg syndrome. So what is restless leg syndrome? The name itself gives it away. It is a disease where patients experience a sensation of discomfort, primarily in the legs. And this discomfort primarily comes in the evening times at bedtime before you fall asleep. And with this discomfort, the longer you stay still, the worse the discomfort gets. But if you get up and walk around, if you move your legs, if you shake your legs, the discomfort gets better. So these are all the cardinal features of restless legs, and this is an extremely common problem in the community. It's one of the most common neurological disorders that we neurologists treat. In Parkinson's disease, this is very common. Up to 50% of patients with Parkinson's disease can have restless leg syndrome. However, there is a slight catch to the restless leg syndrome in Parkinson's disease. Fortunately, the restless leg syndrome in Parkinson's disease patients tends to be milder. It tends to occur at a later age, not at the beginning of the disease process, but at a later age. A lot of the patients with restless leg syndrome report that they have the same problem in their cousin, in their mother, but in Parkinson's disease, typically you don't find this family history, no positive family history. And patients with Parkinson's disease that also have restless legs typically respond well to medication. So there is a bit of silver lining to this story, that restless legs can be present in Parkinson's disease, can be seen in up to 50%, but it's usually responsive, usually milder, and does not, in many cases, cause significant impairment. But that's not true all the time. In some patients, you may have severe restless leg syndrome that needs to be addressed. And whenever symptoms of restless leg syndrome exist, it can make your evenings and night times very miserable because you have a lot of discomfort. You constantly get up and walk around. Of course, with Parkinson's disease, you have difficulty getting up, you have difficulty walking around. So you can imagine the pain and suffering of these patients who need to get up and walk around but can't do that because of Parkinson's disease. So talk to your provider if you have symptoms of restless legs, and proper institution of appropriate medication can help with symptoms significantly. In a lot of these patients, there is an iron deficiency that can be corrected with iron supplementation. That itself can help with the symptoms of restless legs. Now let's talk about another sleep-related condition that can interfere with the sleep quality called REM sleep behavior disorder. And for this, I have a very nice cartoon from Calvin and Hobbes to describe what this condition is. Well, in this first cartoon, the tiger, Hobbes is asking Calvin, what a peculiar dream I had last night. I dreamed I was in a big fight with a ferocious weasel. Well, what do you suppose it means? Now Calvin wakes up and yells at the tiger, it means that you're sleeping on the floor tonight, telling that while the tiger was dreaming, it was just scratching him all the time. So it was basically enacting its dream. The dream that was happening inside its brain was actually coming out as a physical manifestation. And this is exactly what REM sleep behavior disorder is. REM, REM stands for rapid eye movement. And this is the state of sleep where we have vivid dreams. We dream all during the night, but vivid dreams happen in REM sleep. In every one of us, when the dreams happen, our brain has a protective mechanism that prevents the dreams from becoming physical enactments. So all of us dream, but we don't yell, kick, scream, punch. But in patients with Parkinson's disease, because of the damage that happens inside the brain, that protective mechanism gets disturbed. And when that happens, the dreams that go on inside the brain now become physical manifestations. And when that happens, these patients will have vivid dreams as seen by the bed partner, where the patient is yelling, throwing punches, screaming, trying to run, trying to crawl out of bed. Sometimes patients can fall out of bed. Sometimes patients can punch the wall, have a wrist fracture. Sometimes the bed partner gets punched, having bruises on their faces. So identifying this condition is quite important in Parkinson's disease because it's very common in patients with Parkinson's disease. And a lot of the patients actually don't know that they're having this because they are in fact sleeping while this is happening. They are not awake. They are in the dream sleep. Only difference is they are acting their dream out instead of just keeping the muscles paralyzed. They are acting their dreams out. So telling your doctor about such condition is very important. Your spouse, your bed partner can help us out by telling about what happens when the patient sleeps. The interesting thing is this can start many years before you start to have tremor or stiffness. So the REM sleep behavior disorder can predate the motor symptoms of Parkinson's disease by many years. Can be seen in more than half the patients with Parkinson's disease. And the most important thing here is safety of the patient and the bed partner. Make sure you have a soft flooring. Make sure there is a pillow next to you. Make sure there is a pillow or a barrier between the patient and the bed partner so that none of them get injured. Make sure that the environment is safe. Make sure there is no sharp object in the vicinity. You might actually get injured with that. And how do you treat it? Well, the intervention can be very simple. Just taking melatonin that is available over the counter can suppress this dream enactment behaviors. Sometimes the doses have to be high. Sometimes melatonin will have to be replaced by a stronger medication called clonazepam. Rarely we end up using both the medications together to suppress this REM sleep behavior disorder. And when it's present, it can contribute to sleep fragmentation and daytime fatigue. In essence, understanding fatigue and sleepiness in Parkinson's disease is very important. When fatigue and sleepiness exists, along with your tremor, along with your stiffness, along with your slowness, it can make the quality of your life worse. Fatigue and sleepiness, a lot of the times, have to be addressed separately, have to be addressed independently. The Cinemet, the Pramipexole, the Mirapex, the Requip that your doctor gives are to help with your motor symptoms. They are going to help your stiffness, slowness, and all that stuff, but they may not help your fatigue and sleepiness. In some cases, they may make them worse as well. So when present, always discuss this with your neurologist and see what needs to be looked into, see what sort of test needs to be done to identify the problem. And once identified, addressing the problem can significantly improve the quality of life. So with that, I'm going to conclude my presentation. Again, I thank you very much for attending this web series, and all the very best. Stay safe.